Thank you for joining us for this Targeted Oncology Virtual Tumor Board, which is focused on advanced non-small cell lung cancer. In today's Targeted Oncology Virtual Tumor Board presentation, my colleagues and I will review 4 clinical cases. We will discuss an individualized approach to treatment for each patient, and we'll review key trial data that impacts our decisions. I'm Dr. Benjamin Levy, Associate Professor of Oncology and Clinical Director of Medical Oncology at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Today, I'm joined by Dr. Anshu Jain, radiation oncologist at the Ashland Bellefonte Cancer Center in Ashland, Kentucky, assistant professor of therapeutic radiology, Yale School of Medicine. Dr. Lonnie Yarmus, associate professor of medicine and oncology, clinical director of the Division of Pulmonary and Critical Care, and director of the Interventional Pulmonary Research Corps at Johns Hopkins Medical Institute in Baltimore, Maryland. Dr. Sam Corin, molecular pathologist at Maud Pathology Group and director Maud Molecular Lab in Lenexa, Kansas. Dr. Mickey Walker, associate professor of surgery, Thomas Jefferson University, chief of thoracic surgery and medical director of the cancer program at Mainline Health in Bryn Mawr, Pennsylvania. And Dr. Isabel Pishigal, assistant professor, thoracic medical oncologist at Memorial Sloan Kettering Center in Montville, New Jersey. Thank you for joining us. Let's get started with our first case. So thanks for everybody joining. I think we have a full house here. We have radonc, medonc, surgery, and pathology and pulmonary here, which is more than we sometimes have in our own tumor boards. So it's great to have everyone here. Let's start with case 1. Case 1 is a 59-year-old female who presents with dyspnea on exertion. Her past medical history includes hypertension and that's well controlled on medication. She's a smoker. She has a 25-pack year history, moderate alcohol use, and on physical exam presents with some mild stridor. Her FEV1 is 78% predicted, and her ECOG performance status is 1. She ends up getting a chest CT that reveals a 6.3 centimeter spiculated mass in the left upper lobe, 2 enlarged left supraclavicular lymph nodes that measure 1.4 and 1.8 respectively centimeters. Her PET scan confirms the lung lesions in the supraclavicular lymphadenopathy without any evidence of distant metastases, and her brain MRI is appropriately done. It's negative. In terms of how she has tissue procurement, she undergoes a bronchoscopy with a transbronchial lung biopsy and lymph node sampling that reveals grade 2 squamous cell carcinoma with positive nodes in 1, 2R, and 4L. Her staging is a T3N3M0, stage 3C. She gets a surgical consult, and we can talk about the utility of that for stage 3. And the surgeon deems this patient to be unresectable based on the stage, including the extent of supraclavicular and mediastinal disease. And she's currently being referred now as for concurrent chemoradiation therapy with potential for immunotherapy as consolidation on the back end. So this is not an uncommon case. I think at all of our centers we see these cases. It's at least for me been rare to find patients that are stage 3 that are surgically resectable. Many of these patients have either comorbidities that preclude from surgery or are multi-station N2 disease. Lonnie, I'll start with you here because you're the beginning of the story in terms of the patient journey. What are the best ways in patients with stage 3 to get tissue, and how are you getting tissue on these patients as an interventional pulmonologist?
Sure, thanks, Ben. So there's a couple of factors I think that we weigh in. Obviously, procuring a diagnosis is the primary goal, but also providing as much tissue as necessary for ancillary testing and inspection of the airways is frequently an important piece, especially in a patient like this who presents with some degree of stridor. So understanding the thoracic anatomy. So the general approaches, though, are to be as minimally invasive as possible. I think in a case like this, with involvement of the supraclavicular node, potentially looking by ultrasound for a fine needle aspiration is a good start with diagnosing stage 3C. But also the importance of bronchoscopy for airway inspection, as I mentioned, I think is pretty critical. to assess for any extrinsic or intrinsic compression of the airways.
In Baltimore, how common do you think, in terms of all the patients with stage 3, how many of these patients are being referred to you versus, I hear about centers being primarily pulmonary driven in terms of tissue acquisition and others primarily driven by either surgery or interventional radiology. What's the referral patterns in Baltimore?
So they generally have transitioned over to pulmonary, mainly because of the importance of endobronchial ultrasound for mediastinal staging. We frequently still see referrals with interventional radiology being the primary for a CT-guided biopsy. But what often happens there is the referral patterns go from a diagnosis to an oncologic referral back to a pulmonary or thoracic referral for appropriate staging. So I think the importance of understanding the mediastinal component is pretty critical.
Yeah. Now, we were talking before we started here on something that I think, dare I say, is cool and neat, alternative ways to diagnose patients. And clearly this is not standard of care, but maybe this is the next wave of how we may be looking at diagnosing lung cancer, and some of your work looking at breath. Can you briefly just talk about that? Again, not standard of care, but something that I think may be we may be seeing in the near future.
Yeah, sure. So definitely not standard of care and still very much in the discovery phase. But there's been actually decades of research looking at volatile organic compounds in breath, trying to better differentiate and define what those different markers are to specify cancer diagnostics. And technology, I think, is finally caught up. So we think we have some promising signals of being able to definitively diagnose early stage lung cancer patients. And it's even gone on to the fact where now technology has allowed us to devise handheld devices that conceptually might allow patients to track their own breath analysis in a sort of futuristic world.
Pretty neat. I will say, don't try this at home.
Yeah.
But certainly that's something that is next wave.